Well, thank you very much. Thank you very much for being here. And I'd like to share with you the insights of this trial. And I would like to talk about these patients and all of you that work with patients in internal medicine, patients with malnutrition. You know it's so much work to do nutritional care for these patients. And so the question whether you work with these patients is actually worth the effort, I think it's such an important question for you to bring home to your team in the hospital. So we have learned that malnutrition and sarcopenia is caused due to acute and chronic diseases. And there are several links, as you have seen, to it: inflammation, endocrine dysfunction, but also immobilization, so activity is important. And then, of course, anorexia, disease-related anorexia, is a key player which causes malnutrition, particularly in the chronically ill patient with severe illnesses, multiple illnesses. If he's over a longer time has anorexia, he will develop the phenotype of malnutrition. So I think there is no doubt about this link. But the question that is interesting then, can we do something about it? And so several studies have looked at the prevalence also. And so this is, so here you see data from my hospital, where when you do a screening for malnutrition using the nutritional risk screening, we have about 30% of our patients being at risk for malnutrition, and maybe about 20-25% of patients really being malnourished. But the important question is, so here you see that mortality in these patients is increased, but can we do something about it? Is it really a modifiable risk factor? And if we use nutritional support in these patients, are we able to reduce this mortality that is associated with malnutrition? So we did a meta-analysis exactly asking this question. So we included randomized controlled trials that looked at the question whether nutritional support is effective in improving clinical outcomes. And a similar meta-analysis was also about 4 years ago done by Jens Kondrup and the colleagues from Cochrane. And both the meta-analysis concluded that yes, there is promising studies, but there is need for a definite proof that nutritional interventions are effective in improving not only weight or nutritional outcomes, but actually patient outcomes, mortality. So there's need for a large trial to really prove this. And so this is why we then started about 5 years ago this project, which is called EFFORT, so Effect of Early Nutritional Therapy on Frailty, Functional Outcomes, and Recovery of Malnourished Medical Inpatients. And it is a project that really targets this question: can we improve clinical outcomes beyond nutritional outcomes in these patients? It's a publicly funded trial, which was funded by the Swiss National Foundation and also the hospitals. And it's a trial where many co-investigators have participated, and I would like to thank all these co-investigators, particularly also Zeno Stanga, who is co-PI in this study and has helped to motivate over a long time all the people that helped to include these patients and make this trial possible. So we started first with a meta-analysis. We then, from this meta-analysis, we derived a treatment algorithm, and then we tested the algorithm in a randomized controlled trial. So how did we do it? And so here you can see we had a good timing, because the trial took us about 4 years, and just a couple of weeks ago we were able to finally publish the study, and so I'm able to present to you the main results of this study. So here you can see all the centers that participated in the trial. All these red dots are hospitals. We had university clinics, University Hospital, Inselspital, for example. We had larger Kantonsspitäler, but we also had smaller hospitals. So it's a typical medical inpatient population across Switzerland that was included in this study. And what did we do actually? So we didn't do a fancy new algorithm, but we did what nutritional care is about. So first we did screening. So we had mandatory screening in all of these hospitals for all patients going into medical wards. Within 24 to 48 hours, we needed to know whether there is risk for malnutrition. And so for the purpose of this, we used the NRS score, which is standard in many hospitals in Switzerland. So if we had patients that were able to be included in the trial, we then set individual nutritional goals in these patients. We had a caloric goal, which was based on Harris-Benedict equation. We had a protein goal, and so here we wanted to have a high protein intake of these patients. So we had 1.2 to 1.5 grams protein per kilogram per day in these patients. We also looked at micronutrients, and then we had some specific targets if patient had specific diseases. And then this algorithm is nothing new and fancy, but it really is what the guidelines also recommend to do. And we had a very physiological approach then to reach these goals. So we said in all these hospitals, you need to reach the goals, and you have 3 levels to do this. So the first level is work together with your dietitian team, your nursing team, with the hospital kitchen, and use ONS to reach the goals. So use oral support to reach the goals. And in about 90% of the patient, it was possible to reach the goals just with a level 1 oral support. Now, if this was not possible, the team had the possibility then to escalate to either enteral nutrition, and in case of intestinal failure, it was also possible to escalate to parenteral nutrition. So something very easy, but it was important that all the hospitals followed the same approach. So you see then, we did screening of the patients, and we had very broad inclusion criteria. So we wanted to include patients going into the medical ward if they had a nutritional risk, if they were presumed to be in the hospital for at least 5 days. So we didn't want to have anybody coming in just for 1 or 2 days. And of course, the patient had to give written informed consent. We had a few exclusion criteria, which were based on surgical patients, critical care patients, terminal patients, and we had a couple of other ones for which conditions we could ethically not randomize the patients. Now, patients were then randomized into a control group, and so the control group was standard of care. So what's standard of care in Switzerland? If you're in a Swiss hospital, it's a pretty good standard. So you get pretty good food, but you're not being pushed to really eat all this food. So standard of care means the patient could eat whatever he wanted to, so he had the free choice, but there was no plan for him, there was no push for him. We did not really look for him to reach all these nutritional goals. In the intervention group, on the other side, we were going to the patient every day and making sure that he would reach his nutritional goals. Now you can imagine that this part of the study, if you are receiving nutritional support or not, it's very hard to do blinding because the nurse, the physician, the patient, everyone knows whether you get food or not. So this part was not blinded, but we did blinded outcome assessment then after 30 days to see whether clinical outcomes would be different according to the randomization arm. So we screened about 5,000 patients. We had about 2,000 patients which were not eligible for the trial and about 1,000 patients that refused participation, leaving us with a bit more than 2,000 patients that were randomized and then used for analysis later. So here you can see the baseline characteristics. So mean age about 70 years old. BMI was about 25, so these were not all underweight patients, but they had normal BMI. You see NRS score is about a third had 3 points, a third had 4 points, and a third had really severe risk for malnutrition with 5 points or more. And admission diagnosis, infection, cancer, cardiovascular, it's a typical population you will find in a medical ward. Also important, there were a lot of comorbidities in these patients. So these patients were really old and sick, and you can see hypertension, cancer, chronic kidney disease, coronary heart disease was very prevalent in these patients. So our main endpoint and our main goal of the study was really severe complications. So we wanted to see whether nutritional support can reduce severe complications, because we knew that severe complications are associated with malnutrition. And you see, we included more than 2,000 patients, and so the study had a strong power to really meet this goal. If there is an effect on complications, this study was designed to find the effect. We also looked at several other endpoints, at quality of life, at frailty endpoints. We looked at the safety of the intervention, and at other things. So first, of course, it's interesting to see, well, is it feasible if you use a nutritional support algorithm, is your patient actually improving nutritional care? And we clearly found that if you use nutrition and if you push nutrition, you can have increased intake of energy and proteins. And so in this slide, you see in red, you see the intervention group, and in blue, the control group. And you see from day one on, when they were included into the trial, that we were able to increase not only caloric intake, but also protein intake. And in about 80% of our intervention group patients, we reached the goals that were set forth. So not all the patients would reach the goal, about 80%. That's a pretty good result. It's not perfect, but it's pretty good. Now, this is the easy part. So do we improve nutrition? Yes. And I think it didn't need the big trial to see that. But the question is then, does this translate now in outcomes of the patients? And so this is the most important graph of the trial. It's the Kaplan-Meier curve showing you the risk for, or the time to serious complications on the top and time to mortality on the bottom. And so you can see that in the trial we found a significant reduction in the risk of complications when patients received nutritional support. So we had about 27% in control patients complications versus about 23%. So we had a 4% absolute risk reduction, and you can calculate now the number needed to treat, which is 25, meaning that if you treat 25 of your patients with nutritional support, you can prevent one severe complication. Now, we also had significant results for mortality, and so here we had a number needed to treat of about 40. So again, for 40 patients you would treat with nutritional support, you can prevent one death during these first 30 days. So for my hospital, which has about 2,500 patients which are malnourished, this means that we could prevent, if we do this 1 year long nutritional care, we can prevent about 100 complications and about 60 to 70 deaths during 1 year in the hospital. And this shows the effect of nutritional care on the clinical outcomes of these patients. So I don't want to go through all these secondary endpoints, but we found significant results not only for complications and mortality, but also we had less functional decline. We had improvements in the quality of life and also improvements in functional outcomes that were measured in the trial. And importantly, when looking at side effects, we did not see that there were more side effects related to the nutritional intervention. So it was very well tolerated by patients, and it was very effective. So finally, we also planned a subgroup analysis where we asked the question, well, this is a heterogeneous patient population. So is it really that all these patients have a benefit, or is it just some of these patients? So is it possible that a cancer patient has a benefit but not the cardiovascular patient? Is it possible that infection would be a problem? And so just looking over this slide, you can see that actually all these subgroups had a benefit from clinical nutrition. So age didn't matter, gender didn't matter. Also NRS didn't show a significant effect, although patients with a lower risk had lower, just by looking at the graph, there was a trend towards lower efficacy in this group. And interestingly, BMI wasn't a good predictor for your nutritional support, whether it worked or not. So if you have a patient with a higher BMI and he is sarcopenic and at risk for malnutrition, also this patient will have a benefit from the intervention. And then interestingly, the only subgroup where we really found the strongest effect were the patients with chronic kidney disease. So in these patients, we had the strongest effect of the nutritional support. So the study really had a very positive effect then, also in the media, because the study proved that nutrition can have an effect on patient lives and outcomes of patients beyond that was known before. And so I think this really should translate also in our everyday work with the patient. So now we have done the trial, but we have not finished our work with the trial data, because we still have a lot of data to look at. We just finished now a cost-benefit analysis, and we are also interested in mechanistic questions now. So why does nutrition help? So which patients have most of the benefit? And one question, is also about personalization. So in our trial, we did personalization of goals, and also we looked with the patient what's the best way for him to reach the goals. But today we don't have any biomarker of nutrition. So when I have a patient with hypertension, I look at his blood pressure. If I have a patient with diabetes, I treat him and I look at his A1C. If I have a patient with malnutrition, what is my readout? So I think this will be very interesting to see whether there are sensitive markers also to telling us whether our treatment is effective, whether we need to increase treatment or not. So here we also have interesting collaborations looking at novel markers, metabolomic markers, genetic markers, and others. Of course, I think also now we should again look at the guidelines which were published, because a lot of the statements in the guidelines are still weak statements. So they say we should consider doing something, but I think after the trial we can be more strong in our statement and say, yes, we should really do nutritional support in these patients, as mentioned before already. Now, of course, when you want to go to guidelines and change guidelines, one trial alone is not enough, but you need to really look at the whole evidence that supports such an intervention. So when I told you that the initial meta-analysis was actually a bit disappointing because it did not show that nutrition really has a significant effect on mortality, based mainly on the paucity of data and just a small number of patients in the trial. So we now also updated the meta-analysis because there were some other trials also showing mortality benefits, namely the NOURISH trial. And so when you include now these new trials into the meta-analysis, you will see that now overall, when you look at all the trials that have been done, overall there is about a 25% reduction in the risk of mortality. So I think it's a very strong signal, not only from one trial, but actually when you look at all the different trials together, proving that nutrition can have a positive effect on the mortality and survival of your patient. So let me just finish with a little bit looking into the future, because we also did a long-term follow-up. Remember, our intervention was only focused on the hospital stay, and we also wanted to see, well, what happens after the hospital. So we did a 6-month follow-up in these patients. And so when you look at these two curves going, to different directions, you would say, well, it's hopefully, it will stay like that, even if we had only a short intervention. However, probably because we did not continue the nutritional intervention, we found that the two curves, they go in parallel. So the initial benefit of our patient when you stop nutrition seems to kind of, be reduced over time. And so, I think it will be very interesting and important also to understand what are we doing with the patients once they leave the hospital. We can start nutritional care in the hospital, but once they leave the hospital, we have to be sure what to do with these patients as well. So I'd like to conclude that malnutrition is highly prevalent in medical inpatients. It affects about 20 to 30% of our population, and there is strong associations with outcomes. Our trial has shown that systematic screening and start of support improves clinical outcomes and survival in these patients. And it has a positive effect on functional outcome, quality of life, and also frailty. So the nutritional support was mainly based on simple things like hospital kitchen, oral nutritional supplements, and with these interventions you can have a very strong effect, and about 80% of the patients were able to reach the goals. So I think now it's really time to implement and to change the way we treat our patients with risk for malnutrition in the hospital. And with that, I'd like to close and thank you very much for your attention. Thank you.